So welcome. Hello, everyone. This is a great crowd for our first public health grand rounds at the College of Physicians this year. I'm Priya Mamin. I'm the chair of this section of Public Health and Preventative Medicine, and I am very happy to welcome you all here tonight for a really interesting panel and, I'm sorry, I'm touching things, with a great panel of experts. So tonight we're going to be talking about the role of harm reduction in public health. Just some logistics and some background. The Philadelphia Public Grand Rounds was developed by our prior chair, Dr. James Bueller, who I saw walk in and is here somewhere. And the goal was to really use this platform to address important public health issues in the Philadelphia region using local speakers from different backgrounds and disciplines. We hope through the College of Physicians as well as the section on public health and preventive medicine to really generate new ideas and collaborations. And we already have a very robust, very strong public health community, and it's always fun. We were with a couple of the speakers just mentioning how fun it is to see everybody that we tend to see in different avenues and venues. So it's always great to put our minds together. This program is co-sponsored, College of Physicians, as well as the Philadelphia Department of Public Health. And we also acknowledge, gratefully acknowledge funding from the Independence Foundation as well. So just a run of the night, or the evening. We have a panel of 4 fantastic speakers. And then we will keep all the questions until the end, so everybody has their time to ask questions, doesn't go into the next speakers. If you enjoy the evening, if you enjoy our program, then I encourage you to join us. We always want new members to the section of public health and preventative medicine. We are looking to expand our programming beyond just the public health grand rounds and have smaller, maybe more intimate kinds of talks and discussions and a wide variety of different programs. So if you are so inclined, we would be very happy to take any donations. And then, the best of all, please stay for the reception afterwards. It's a great time to talk further with the speakers, but also talk amongst all of ourselves. We have a great group of institutional sponsors as well, including all of the schools of public health, as well as, again, the Department of Public Health. So just some the other logistics, the bathrooms are in the back. If you go through that door, there are a set of 3 bathrooms. The reception will be held next door right after. And once again, please hold your questions until the end. So I am going to just give the very briefest, what is harm reduction 101. My dear friend and colleague, Jose Benitez, who is also a fellow of the College of Physicians, was going to give this talk. He is, perhaps there is no greater expert than him, certainly in the city. But he, as busy as he is, was double booked somewhere else. So I will be giving this in his stead, so bear with me. I am not so, like eloquent as Jose, but I'll do my best. So what is harm reduction? Harm reduction really is very simply a practical set of public health strategies. It is designed to reduce negative consequences of high-risk behaviors in general, with a focus on drug use as well. But at the end of the day, it promotes healthy individuals and communities. And it is not at all foreign to the way we in public health function. Some examples of harm reduction in other areas are things like sunscreen and seat belts, speed limits, cigarette filters, birth control. All of this is based on rigorous research and evidence of proven strategies. And their harm reduction as a mentality, as a philosophy, is nothing more than trying to understand the issues that make something far more dangerous for individuals and communities as a whole. The principles of harm reduction are fairly simple. It's based around the idea of designing public health interventions that minimize harmful effects of drug use. Understand drug use as a complex, multifaceted issue that encompasses behaviors from this full spectrum of severe abuse to total severe use, my apologies, to abstinence. It meets the fundamental idea of harm reduction meets people where they are in the course of their disease. Ensures those people who use drugs have a voice, have a voice in the creation of their programs that address their needs in a meaningful way. And affirms people who use drugs are the primary agents of change. And finally, the principle of harm reduction looks to empower communities to share information and support each other. This graphic from the Harm Reduction International Organization shows just a very small amount of financial investment in harm reduction strategies has exceptionally large return of investment. With the global war on, With the global war on drugs, the annual budget is over $100 billion, but with very small incremental changes that could significantly decrease HIV-related deaths, HIV infections, and overall mortality. So finally, harm reduction aims to identify the harms related to engagement and behaviors, but ultimately works to increasing overall health and well-being. The focus is not on punishment or rehabilitation, but to reduce the harm that comes along with particular activities. Harm reduction recognizes that policy, class, social isolation, past trauma, and gender-based discrimination have an effect on people's vulnerability and their capacity to deal effectively with treatment and ongoing care. The priority is service delivery with the aim of improving public health and the humane treatment of all people as its core value. And finally, harm reduction preserves public health by offering options to those most marginalized within the health system. The goals of harm reduction are simple: reduce mortality, prevent disease, prevent overdose, ongoing links to medical care and social services, treatment of drug dependence, and empowering participants, communities to reduce stigma. With that, I'm going to begin introducing our speakers, each of whom bring their unique perspective and expertise to the discussion. This evening, we are lucky to have Evan Anderson. Dr. Anderson is a public health researcher. His research explores the relationship between laws and population health, with a specific focus on bridging the gap between legal and epidemiologic research. He teaches health policy at the University of Pennsylvania. Dr. Anderson was previously the Senior Legal Fellow at Public Health Law Research, a national program of the Robert Wood Johnson Foundation, and a Senior Fellow at the Centers of Law and Public Health, a collaborative between the Johns Hopkins Bloomberg School of Public Health and Georgetown Law Center. Next, we have Dr. Alexis Roth. Dr. Roth focuses her research on understanding how individuals, social and environmental factors influence health disparities. She utilizes mixed methods and community-engaged research approaches with the goal of working with community members and advocates to co-create sustainable solutions to public health problems. Two of Alexis's areas of interest are the intersection of gender and drug use on women's sexual health, as well as the evaluation of interventions to combat opioid-related overdose crises. Dr. Roth has also recently been trending nationally as one of her studies was cited in Rolling Stone. So we have a national rock star in our midst. Dr. Ben Cucciaro graduated from Drexel University and completed a residency in family medicine and community health at the University of Pennsylvania. He currently serves on Prevention Point Philadelphia's Mobile Addiction Medicine Unit is a lecturer in pathophysiology for USC Suzanne Dwork Peck School of Social Work, and as an adjunct fellow within the University of Pennsylvania Center for Public Health Initiatives. He maintains a primary care practice at Care Clinic on 12th and Callow Hill. And last, but by no means least, Mr. Devin Reeves. Mr. Reeves is a person living in recovery. He is a community organizer and grassroots advocacy leader who's worked on the expansion of access to life-saving medicines such as naloxone, implantation of 911 Good Samaritan policies, and the development of youth-oriented systems. He wanted to build constituencies of consequence that will lead to meaningful public health policy changes around substance use disorders. Mr. Reeves is the co-founder and executive director of the Pennsylvania Harm Reduction Coalition. He received a master's in social work from the University of Pennsylvania School of Social Policy and Practice with a focus on community and organizational change, and has a BA in Human Services from Lynn University. We will begin our presentations with Dr. Anderson. But before we do so, I just wanted to take a moment, now everybody's settled in the room. This is an important day both for our country, for public health in general, and September 11th is a date that we honor and remember for all who were involved, all who lost their lives. So if we could just have a brief moment of silence together to honor those who've fallen. Thank you. And with that, I introduce Dr. Evan Anderson.
All right. Oh, it's a little loud. Is that all right? Good afternoon, everyone. It's wonderful to be here. Honored to be speaking with these amazing panelists, and really delighted to see so many familiar faces out there. I think that works. That's me. So I want to start a little bit with the Titanic, right? A big, terrible accident, tragedy, one which had a very particular distribution of mortality, right? So mortality on the Titanic, you had this profound graded relationship between ticket price and survival, and then you also had this really pronounced effect between men and women, right? So I always like to start there. The sort of key takeaway there is, that patterning of survival had nothing to do with the cold tolerance of water or any other biological difference to the extent that you could identify one, right? That is a story about rules. It's a story about rules and the translation of rules and how those rules end up having a really profound impact at the population level. So I'm a public health law researcher. What that means is I think about law as a structural risk factor, right? And the basic proposition that I really believe in and that I like to talk about is this idea that most mortality and morbidity at the population level is determined by our decisions, right? By our behavior. And our behavior is shaped very powerfully by our environment. And then our environment is, of course, shaped very powerfully by laws and policies, both in the formal sense, laws in the books, but also in the more informal sense, the way laws get enacted on the street. We have some wonderful examples where law has been this powerful structural driver of health, child restraint laws and the amazing job we've done reducing child morbidity and mortality. But then we have also examples where law is in fact the primary driver of harm. And I will argue in the next couple of minutes that that's very much the case with drug policy. Drug policy is a cause of many of the harms that we see in our current opioid syndemic. So I went to law school really interested in disparities, and I particularly envisioned myself going and suing people who discriminated against people who I was particularly interested in HIV at that point, but also just sort of being in a courtroom. I was really struck by this idea that survey data suggests that drug use is similar across racial and ethnic groups, but when you look at the distribution of harms related to drug use, you see this very distinct patterning, right? And again, there's no sort of plausible sort of biological explanation for that. Those processes are driven by laws. The laws that are written, laws that restrict access to syringes, laws that criminalize different activity, and then how those laws are applied enforced on the street. So we have this sort of interaction between law and the enforcement of law, things like stop and frisk, which actually become drivers of harms, right? So law is one of the sort of key drivers of our current opioid syndemic. It's not to suggest that heroin, alcohol, tobacco, all sorts of activities don't have harms, right? What it does suggest, though, is that our inclinations to use law have often been wrong-headed. We tend to latch on, as Devin's laughing up there, right? We tend to latch on to prohibitionary regimes. We tend to think that we can command and control our way out of problems, right? Oftentimes that creates a lot more harm than good. There's been a lot of discussion about fentanyl, right? And the harm of fentanyl. Fentanyl is a case study in what you might call the iron law of prohibition. This is the idea that the more you criminalize something, the more you apply command and control, prohibitionary interdiction type efforts, the more potent that thing becomes, right? So you're looking at a depiction of the consumption of distilled spirits during Prohibition, right? People liked beer before Prohibition, they liked it after, they probably liked it the same during. But if you're a bootlegger, it's a lot easier to move a small amount of grain alcohol than it is to move large casks of beer, right? So you can make an obvious analogy now to fentanyl, right? The more we've tried to force opioids out of use through supply-side measures, the more we've gotten more potent opioids. So, I don't know how I'm doing on time, it's pretty short. So how do we back our way out of this? I mean, one of the problems is that our agencies get very big, and they seem to grow, and they never seem to shrink. And this applies, sort of across our regulatory schemes. We really shouldn't have, the FDA and the USDA. One regulates chickens, one regulates eggs, but we can't just kind of bring ourselves to just like scrap it and start over again. So true with a lot of our drug enforcement agencies, where they've grown so large. It's very difficult to get out of the lobster trap once we've gotten into them. And we've only just started to appreciate this idea at a sort of popular level, that we just can't ban and punish our way out of problems, right? We've been sort of caught in the last 3 or 4 decades in this idea that we can prohibit and we can punish and we can deter our way out of these problems. We very much can't do that. I look at our current moment in a sort of hopeful way. So political scientists talk about the idea of punctuated equilibrium. This is the idea that we have long periods of stability punctuated by violent change. I see us in a moment like that right now with policy. It can seem really dismal and grim sometimes, our politics and our policy making. But just think about marijuana, right? And think about how much profound change we've had in 10 years. I think much of that is sure to move into other areas of drug policy. So I'm going to really end with a couple points and talk about a couple interventions, which I think are particularly important to think about through a legal lens. Generally, though, on the sort of left side of the ledger, I offer some just sort of key points to think about. One is we need to think really seriously and thoughtfully about our interventions. We have a tendency to think that prescription drug monitoring databases and other sorts of interventions will have a benefit. We don't think about the incidental negative effects. Or we think only at the population level of mean effects. We don't think about heterogeneous treatment effects, the idea that some people can benefit, some people can be harmed at the same time. We ought to be really thoughtful about those. We need to get out of this idea that we can punish our way out of these problems, right? As much as possible, we want to move away from using coercion and punishment to achieve drug policy aims, or public health aims more broadly. The evidence is really, really clear. People engage with treatment when they're ready to do that and when it's available. They don't engage because of leverage from a drug court or through some other system. We can use law and legal reform to make services more available. So That's an important goal and one that we can do through crafty reform. 2 minutes. Also, sort of as a broad macro level, we need to think about returning more authority to localities and states. Federal involvement in drug policy, whether in the practice of medicine or whether specifically in criminal law, that's actually not an old phenomenon, right? Until the 1970s, most regulation was at the state level. As the federal government moved into it in the 70s, we've had an influx of criminal justice policies that are much, much more harmful. Devolving authorities back to localities and states would have many benefits, and it's something we should really encourage. Closer to the ground, right? Able to engage in innovation, which we can then study, learn from, and disseminate into other places. 3 interventions that I'm sort of particularly excited to see developing, and that I think we should invest in even more. First one is pre-booking diversion programs. This is sometimes called PAD. This is when an police officer is responding to a person experiencing a crisis in the community. In many instances, that would result in arrest previously. We have a pretty substantial pilot program in the city right now where officers are empowered to actually take that person directly to a treatment facility instead of an arrest, right? That's good on sort of all levels, right? There's also a mechanism where a community member can just flag down a police officer and say, I'd like to come into the PAD program. And there have been over 150 of those, which I think is really telling. We ought to get rid of all barriers to medication-assisted treatment, medication treatment. I think Ben might say a little more about that. And I'm really a strong believer that we can do not prescription heroin, which is done in many European countries, but prescription hydromorphone. I think there's a clear legal path to do it, and I think we should try it. And I think it's happy to take more questions on that later. Finally, we need to invest more in the social determinants of health. And I see one legal lever for doing that, forcing hospitals and health systems to spend their community benefit dollars on the social determinants of health out in the community, right? Because that's where I think you'll see a lot of the bang for those bucks. That's all I have. Thank you so much. Yeah.
Thank you, Dr. Anderson. Next, we have Dr. Roth talking about harm reduction and infectious diseases.
All right. I do not have Evan's slow canter, and I have a lot more slides, so I'm going to just jump right into it. So I'm delighted to be here and a part of this incredible panel of folks and to see so many wonderful, friendly faces in the room. So over the past decade, rates of hepatitis C have been increasing across the United States. Rates of hepatitis C have more than tripled in the past decade, with most new infections occurring among people who inject drugs. Rates of soft tissue infections, which when left untreated can lead to sepsis or endocarditis, are also increasing, and these soft tissue infections are the most common reasons that people who inject drugs present to the emergency room or are admitted to inpatient hospitalization, all of which have incredible economic costs. And then in addition, for the last several decades, rates of HIV have been low and stable at less than 10% of all infections. However, recent outbreaks among people who inject drugs have been observed in Seattle on the West Coast, rural Scott County in the Midwest, and Lowell and Lawrence, Massachusetts in the Northeast. We've also seen a 115% increase in cases of HIV among people who inject drugs in Philadelphia in just the last 2 years. And while 2019 case reports are still being submitted and processed, it's unlikely that the trend has reversed itself. This is the first time that we've seen an increase in this group in Philadelphia since the 1990s. This begs the question, what's happened to destabilize trends in infectious diseases in this population? And so I'd like to offer a few explanations for why we're seeing increasing rates of infection, and then later talk about some of the things that we can do to try and reverse those trends. First, the number of people who inject drugs has grown sharply in recent years as a byproduct of the opioid epidemic. When people in active opioid addiction are unable to access prescription plan medications, they turn to less expensive, more accessible forms of opioids, including injectables, especially in a situation in which treatment can be hard to access. Second, fentanyl and synthetic fentanyl have an increasing market share in drug markets formerly dominated by heroin. So these are some data from the Philadelphia Department of Health. Here we can see that drug seizure data suggests a threefold increase in fentanyl and fentanyl analogs from 2016 to 2018, the same time period in which we saw those cases of HIV go up. If you look at the last quarter of 2016, heroin represented about 34% of drugs seized, while fentanyl and fentanyl analogs represented about 9%. In the first quarter of 2019, they switched positions, with fentanyl and fentanyl now dominating heroin. So why does that matter? Why do we care about fentanyl saturation? And what does it have to do with infectious diseases, you might be wondering? Well, in fact, it matters quite a lot. Compared to heroin, fentanyl has a shorter half-life. This means people have to use more frequently in order to stave off painful withdrawal. In Philadelphia, we've always had a relatively pure heroin supply. People could use 2-3 times a day. They could hold down jobs. They could be stable. With fentanyl, people are reporting double and triple this number of daily injections, and the sheer volume of injections is destabilizing to their lives. Beyond that, with injecting many more times comes an increased risk of parenteral exposures if you don't have a sterile syringe to use each time you inject. And then beyond injection-related risk, people who inject also have greater susceptibility to HIV and other sexually transmitted infections from engaging in paid or transactional forms of survival sex in order to obtain the resources that they need to procure their drugs. And this use of survival sex to obtain drugs is a gendered experience, with women experiencing it more often than men. Fourth, there's evidence to suggest that having one infectious disease may increase your susceptibility to contracting another. In Scott County, Indiana, they performed some molecular epidemiological analysis of hepatitis C samples among people screening positive for HIV during the outbreak. They found that HIV transmission was facilitated by existing hepatitis C transmission networks that had also likely perpetuated hepatitis C in the community for years. Similarly, we know that bacterial sexually transmitted infections increase the likelihood of HIV acquisition by 2 to 5-fold. So having one disease matters. Fifth, people who inject drugs have difficulty navigating rigid healthcare systems that require making and keeping appointments within traditional business hours, and they often face stigmatization from clinic staff for their appearance, their drug use, or reporting engagement in transactional sex. And then finally, there's been limited public health investment in evidence-based harm reduction strategies to prevent infectious disease in this group. And so just as an example, syringe exchange programs are a mainstay of the harm reduction movement. For more than 30 years, research has shown they effectively reduce HIV and hepatitis C and increase access to drug treatment among people who inject drugs. In spite of their proven effectiveness, as of 2017, SSPs, so this is a map of the US, showing the legality of SSPs across the United States. So you've got the dark blue states where you can legally access the light blue states where you have local jurisdiction, and the red states where SSPs are still illegal, which is 15 states, despite 30 years of evidence to show that this intervention works. And if you look at in Pennsylvania, Philadelphia, and Pittsburgh, we have syringe services programs, but many other counties with high demand do not. And despite having syringe services programs, in order to provide the level of coverage needed to meet client needs, many syringe exchanges are struggling. So if we take a look at Prevention Point, which has been providing syringe services since 1992, they gave out 3.2 million syringes to over 14,000 unique exchangers. But if we just do a quick back of the map or napkin type of calculation, and we think about, okay, 14,000 exchangers, injecting 5 times a day, we'll round it down to 3, 12 months in a year, we'll round it down to 9, they'd be needing to give out closer to 11 million syringes in order to meet client needs. They just don't have the budget and the capacity to be able to do that. So taken together, there's a lot of evidence to suggest we really have a perfect storm as it relates to people who inject drugs and infectious diseases. We have a drug market that increases susceptibility to disease in a population who has some endemic infectious disease, which may increase their susceptibility to others, and a public health system that hasn't kept up with the need for evidence-based prevention. And while I didn't previously mention it, we should talk about the failed and oppressive racist war on drugs and increasing social isolation, all of which facilitate increased drug use. So then the question becomes, how do we move forward with interventions that curb infectious disease in this population? And I think it's really important to consider, this says HIV, you could put in any other infectious disease that you like. We need to think about how to tailor and implement programs that combine evidence-based biomedical, behavioral, and structural interventions. And then we need to implement them in ways that meet clients where they are using, to quote Ben Cocchiaro, who's up after me, patient-centered, recovery-oriented, and trauma-informed methods of program delivery. While this may seem like an impossible task, Ben and I are here to give you 2 concrete examples of how this can be done. For my part, I'll share with you some research on a scalable model to increase access and uptake of pre-exposure prophylaxis among women who inject drugs. Okay. So pre-exposure prophylaxis is a biomedical HIV prevention tool. The only current FDA-approved form is a daily medication. And if people take it every single day, it can be over 90% effective. Project SHE is one of the few implementation studies being conducted in the United States. It was funded by the National Institutes of Health to assess barriers and facilitators to PrEP uptake, retention, and care and adherence among women who inject drugs in Philadelphia. The study's being conducted in partnership with Prevention Point, and the clinic runs during Ladies' Night on Tuesdays from 6 to 9 p.m. Ladies' Night is an invaluable program that serves 40 to 60 women a week and provides them with a safe space, food, shower, clothing, things that people need. By embedding the clinic within an existing and well-utilized social service, we're meeting women a space that they already use at a time that many consistently already come in for services. So just to give you a quick snapshot of our work, I've just provided a couple of summary statistics. It took us about a year to enroll 100 women, and that's because we had a supply problem, not a demand problem. I didn't have enough clinicians, rooms, or research staffs to meet women's needs. Of the 100 women that we enrolled, 93 women expressed an interest in PrEP. Of those, 85% came back a week later to pick up their prescription. Retention and care was higher than we expected and similar to populations facing fewer vulnerabilities. So we retained 83% of people at 3 months and 61% of 6 months. And unfortunately, adherence are low. When we used a tenofovir-based urinalysis test, which just looks at drug levels on board, we see that of the women who reported consistent adherence, only 26% had an indication that any drug was on board, and we had even lower levels of protective PrEP, which suggests that there is a demand for PrEP, that women are enacting their intentions towards PrEP, but they need some sort of additional supports to be able to help their behavior match their intention. And so I'm going to go ahead and just call this a success, right? We did something that people didn't think that could be done. We got people on PrEP, and they've continued to come back, and so now we have something that we can work with, and this is why. Because people like being met where they are. 53 of 54 people that we asked reported that getting PrEP through the syringe exchange would be easier than getting it from a regular medical clinic. And I'll let one of our participants speak for themselves and give you just a quick second to read this quote. And so I'm going to end by just hoping that you guys remember a couple of things. We have increasing rates of infectious disease among people who inject drugs, including HIV, for the first time in a long time. Without swift action to curb disease, these rates of disease are likely to continue to increase given drug market factors. We need novel and evidence-based harm reduction, not hard reduction approaches, and we will be most likely to succeed if we implement a combination of structural, biomedical, and behavioral interventions. Our existing care paradigms don't attend to the needs in the context of the current opioid crisis. And while I partnered with the Syringe Exchange to provide care, there are lots of other innovative patient-centered models that could be replicated for prevention, diagnostic, or treatment efforts. And then finally, shifting towards patient-centered, recovery-oriented, and trauma-informed programming is the most likely way to engage and retain people who inject drugs in care, regardless of where it's based. I'd like to acknowledge the panel organizers, my participants, co-authors, and funders, and if anyone is interested, these are my references. Thank you.
That was like straight power. That was good. Thank you so much, Dr. Roth. So next we have another power player, Dr. Ben Cocciaro, titled How to Throw a Life Preserver So People Can Actually Catch It.
Okay, well, thank you. It's certainly an honor to be here tonight. In this talk, I hope to investigate some cultural and systems issues impacting the treatment of opiate use disorder. I should state from the outset that my views do not necessarily reflect those of my various employers. So, despite leveling off in Philadelphia, overdose deaths remain high, and I'm talking like firearms plus car accidents high, more deaths than diabetes high. Philadelphia in particular has an overdose death rate that's twice the national average. So why is that? Well, the answer is likely that magical public health word multifactorial. Let's see if we can't factor out some things with some comparative history. 127 years ago, the Philadelphia County Medical Society met to discuss the opium epidemic and tried to grapple with its causes. So let's blame the pharmaceutical companies, perhaps. Dr. Joseph Hoffman here ascertains the frequency with which opiates are prescribed, discovering that 3 out of 5 prescriptions contained some form of opioid. Of course, regulations ultimately stopped the patent medicine industry for a time, and a century later, from the years 1990 to 2011, opiate prescriptions tripled. Perhaps we fell back into our old habits of injudicious prescribing. J.P. Crozer-Griffith here presciently iterates the CDC guidance from 2012 against prescribing for non-cancer pain that is chronic. Though, paradoxically, we did not see the worst of our overdoses until our prescribing rates fell. One novel change here is the advent of fentanyl, which, as my colleague Dr. Roth describes, is 50 times more potent than heroin by volume, and as my colleague Dr. Anderson describes, is easier to transport and conceal from law enforcement, making it harder to create a product of consistent purity from bag to bag, resulting in fluctuations in purity that are an independent predictor of overdose deaths. Supply chain disruptions secondary to law enforcement involvement may be implicated in this process as well. Further, decreased half-life compared to heroin doubles the number of injection events per day, again as described by my colleague Dr. Roth. Fentanyl then is certainly new in the same way that morphine and the hypodermic syringe were new. Of course, this was back when most of the afflicted were members of the quote-unquote refined and cultivated class of society, physicians and Wall Street speculators, and generally treated more kindly than our systems presently treat people who use drugs, but I digress. We have medications that work for opiate use disorder. We call them medications for opiate use disorder. We used to call them MAT, or medication-assisted treatment. Why the change in nomenclature? It's because for some patients, MAT, medication, is the treatment. It's not assisting anything. Recent work from Philadelphia's own Robert Ashford confirms that our words have real and lasting impact when it comes to stigma and service utilization, so we should pay heed to these words. There are 3 effective medications, methadone, buprenorphine, and to a lesser extent naltrexone. We know that they save lives, we know that they save money, and we know that it creates space for healing and other important work, again, by decreasing the frequency with which a person needs to obtain and administer the medication on which they are dependent. We should note that the majority of people in recovery are not teetotalers, And if we are to be recovery-oriented, our programs must reflect that. Our data reflects that. We know that it does not require total abstinence in order to prevent death. It should be noted further that opiate substitution was the standard of care in the 18th and 19th centuries, but following the racially motivated Harrison Act of 1919, the practice was made illegal and heavily regulated for much of the next century. So, where has that gotten us? Williams, in 2019, this is the same Williams, by the way, who created the HIV cascade of care model, analyzed NISDA data from 2016 and estimated there to be 2 million folks with OUD in this country. Half of those folks get diagnosed by a medical professional. Half of them get engaged in care. 20% of that number are then started on one of our 3 evidence-based treatments, and the vast majority of those folks, that infinitesimal percentage that starts treatment, the vast majority of them leave treatment within 6 weeks. So we have capacity increasing and access lagging. In Philadelphia, we tripled the number of people taking buprenorphine. As of 12 of 2018, DBHIDS had over 12,000 treatment slots, of which up to almost a quarter were available, at least on New Year's Eve. These are great strides. However, with an estimated 50 to 70,000 people in this city using heroin, what we might presume to be excess capacity is likely anything but. So why? There are many barriers. The answer to why so few folks are accessing treatment is likely, again, multifactorial, but I'd like to focus today on the role of stigma, trauma, and structural violence. So here we have a map of trauma in Philadelphia. The darkest zip codes here, the darkest green, are areas where where 45% or more of the inhabitants have been exposed to 4 or more adverse childhood experiences. 4 or more is important because that cluster of exposures could explain up to 2/3 of injection drug use. That's from Dubé, 2003, Journal of Pediatrics. This is not new information. And if you overlay a map of overdoses on top of our trauma map, you see a pretty tight correlation. And indeed, OD risk increases by 10% with each adverse childhood experience. By the way, 127 years ago, we were thinking about this too. So if trauma loads the gun, stigma fires it. By exposing patients with impaired coping mechanisms to environments of hostility and discrimination, asking superhuman feats of them and then punishing them brutally when they fail, it's no surprise that this is going to decrease care seeking and increase dropout from programs, increasing AMA discharges. We're throwing the life preserver in the complete opposite direction of the patient and expecting them to swim through a sea of paperwork. Stringent program requirements are one way in which we make this happen. Required counseling, for instance. We have 4 randomized controlled trials totaling over 1,000 patients demonstrating no difference in retention, and yet many treatment programs in this city still require counseling as a mandatory part of treatment, or else you're kicked out. Mandatory abstinence and treatment adherence, mandatory attendance, and of course the smoking ban are also likely contributing factors. So, with all this in mind, Prevention Point designed an intervention that was person-centered, recovery-oriented, and trauma-informed. Starting from the perspective of the person who uses drugs, we offer a service that meets them where they are, addresses immediate needs of wound care, overdose prevention, shelter, and medications for the use of for opiate use disorder. The team is myself, a medical provider, a wound care provider, a case manager, a certified recovery specialist, and we offer the darkest green circle. That is the service that is available on the bus. The picture in the background is the view from outside the back window. We do rapid intakes, we do same-day assessments and starts, as well as connection to ancillary services within our organization. That's the wider circle. That includes a mailing address, meals, shelter, a syringe service program, as well as Hep C and HIV testing and treatment. Beyond that, we have outside referrals to legal assistance, primary care, behavioral health, intensive outpatient and inpatient substance use programs, as well as permanent supportive housing, though there is, of course, not nearly enough of that. By centering the client in this way, meeting them where they are, and partnering to take them where they want to go, we hope to improve care for them and to affirm the dignity of our participants. So, where's this gotten us? In the first 5 months, we enrolled 118 new participants, the vast majority of whom were homeless or unstably housed, and a strong minority of whom were uninsured. Polysubstance use was common, cocaine and methamphetamines making up the large portion of the polysubstance use. In terms of outcomes, more than 3/4 came to their second appointment, and over a third were retained in care at 120 days. Krawchuk in 2019 published the results of a similar intervention in Baltimore and found similar results as well, so we're at least on par with Baltimore. We did face a number of challenges, culture and stigma again being chief among these. We can set up a trauma-informed, person-centered intervention anywhere we want, but it's still going to be in the middle of a racist and oppressive drug war. We have been having problems with our linkages to care, specifically with behavioral health. Waiting times for a psychiatry appointment are sometimes over 1 month. And of course, Maslow's hierarchy. I had a patient years ago who asked me, "Doc, why the hell should I go into treatment if they're just going to spit me back out onto Kensington Avenue, homeless and unemployed?" So, how do we conclude this? Opiate use disorder is socio-relational, chronic. People are dying, progress is stalled, barriers are preventing most folks from accessing treatment. So, given that we've spent the last century trying to do the same thing and expecting different results, where do we go from here? I think it's up to us to bridge that gap. We need to destigmatize, starting with our language. It's a good first step, and there's evidence that even online trainings can have lasting impacts at 6 months. But going deeper than that, we need to train staff to develop a neurobiological and socio-relational understanding of substance use. We need our providers to check their countertransferences at the door, and we need to co-locate our services. Where we can't do that, we need to provide strong referral networks with warm handoffs, especially for housing and behavioral health interventions. And we need to meet patients where they are, take them where they want to go, and allow for multiple concepts of recovery. Further, we should consider the ways in which our programs pit staff against patients. Doing this, we need to work within our organizations to secure the resources necessary to care for these populations. And when our organizations won't work with us, we need to organize and make them work with us. Finally, we need to work outside our organizations to affect policy changes. But I'll refer to my colleague Devin Reeves on that subject. Thank you, and thank you for your time.
Everyone need to take a breath. That was fantastic. I'm having the best time. I don't know about everybody else. I would say, it's hard to top everything we've had so far, but I have no doubt Mr. Devin Reeves will top it. Devin is here to talk about the role of harm reduction in public health through his vantage as a person in recovery and a community advocate.
All right, good evening, everybody. Wow, that was really lame. Good evening, everybody. Evening. There we go. The clicker thing doesn't work. That always throws me off. All right, so I'm from the Pennsylvania Harm Reduction Coalition, and we got together with all of the syringe service programs in the state, and we developed this mission statement, and it was terrible, but it was very traumatic, so you all have to read it as well. The mission of the Pennsylvania Harm Reduction Coalition is to promote the health, dignity, and human rights of individuals who use drugs and communities impacted by drug use. And then I spent the next 2 years figuring out the next 3 bullets. We do this by increasing knowledge and capacity of those impacted by social inequity, criminalization, and stigma, educating key decision makers on effective policy and advocating for its implementation, building community power and leadership through training, outreach, and engagement. And if you want to see me be sassy on social media, you can follow us on Twitter or Instagram at PA Harm Reduction. This is a picture of me looking cool in front of Philadelphia. Makes me feel like kind of like a badass. That's why I put it in presentations. In general, everybody cares about the opioid epidemic because the newspaper tells you should. You see it on the TV, you see it on 60 Minutes, but you don't really care about it until it's your cousin, your nephew, your loved one. It's just somebody else. And the illustrious speakers before me kind of hinted that the war on drugs is super racist. And I just want to say we're having a conversation about the war on drugs and public health and harm reduction in possibly the whitest room I've ever been in. This room has possibly 50 old white men on the room who I'm sure are giants in their field and did great work. However, The opioid epidemic in white communities is different than it is from black communities. We lift up the stories of little Johnny from the main line who was playing lacrosse and hurt his shoulder, and then he got hooked on heroin, and he deserves all the help he can get. But that's not my story. I'm a third-generation addict. My father's father had a problem with drugs that was so bad, the people in his small rural Arizona town took his child away from him, and he was raised by a woman named Veda. My father had such a big problem with drugs that he was kicked out of the military, destroyed his whole life, and I was raised by a single mother. Now, she provided for me very well, but I made the same poor decisions and maybe had the same genetic factors to develop a substance use disorder, and I was only able to get well through access to resources. And all I want is everyone else to have access to the same resources that I did. And since I'm in a room of doctors, and I already know you don't really care about the overdose epidemic, I'm going to talk to you about communicable disease in the hopes that this may inspire you. In a lot of ways, this has been touched on by my colleagues, but this is the unspoken epidemic. This isn't sexy. It's not in the newspapers, but you should be paying attention to it. Heck, you guys went to school for like 20 years to become doctors, so you know something about this. So we had an outbreak of HIV amongst people who use drugs in Indiana because Mike Pence is a terrible governor. He shut down all the Planned Parenthoods because he didn't want people to have access to abortions, and it also was the chief place where people could get their tested for HIV, and it led to an outbreak of HIV in that community. And people like me were ringing the bell, a small town doctor was ringing the bell, and nobody did anything until it was already too late. And some smart woman at the CDC says, maybe there's other places that may have the same risk factors for an outbreak. And it turns out the entire state of Pennsylvania is at risk of an outbreak of HIV and hepatitis C amongst people who use drugs. As a matter of fact, three of the top 220 counties are in Pennsylvania, and none of those counties have the correct interventions in place to address that risk. And we're not just going to talk about HIV and hepatitis C because, as my colleagues mentioned, soft tissue infections are a huge risk factor, and we talk about overdose deaths going down, and our elected officials and key decision makers can't wait to hold a press conference, and I'm in the corner throwing up all over myself because things aren't getting better. When somebody dies of endocarditis or some other soft tissue infection, that's not in the numbers. When somebody falls over and hits their head because they're not down on Kensington Avenue, those aren't in the numbers. So when you tell me that things are getting better, I don't know what the heck you're talking about. The people that are on the front lines don't know what you're talking about. Things aren't getting better. They're getting worse. And this idea that if I should recover like this, like every day I'm more recovered and doing better, is so pervasive in the medical community, amongst clinicians, that if somebody actually makes a mistake, social workers, medical professionals, nurses, y'all turn into cops. You can't wait to report somebody to their PO because they had a reoccurrence of use. You can't wait to kick them out of their program because they didn't follow all of your made-up rules. This is what recovery looks like. When somebody has a step back, we pick them up and we help them go forward. Harm reduction is a body stance, right? Harm reduction looks like this. What's going on, fam? Are you hungry? Let me get you a sandwich over here. You need some clean socks? You need some sterile syringes? What can I get you to help you today? The therapist, the social worker, the doctor perspective looks like this. You got to do this. You got to do that. And if you don't do this, you can't get services. Which to me looks a lot like this, which is the other way we like to respond to people who use drugs. And I'm really tired of it. We know that there's multiple ways to recover, not only 12-step fellowships, but houses of worship, and all of those are valid if that's what somebody wants. We cannot ram any of these interventions down people's throat because they will not find wellness. We know that all three forms of medication-assisted recovery or just medicine work really well to help people get well, and we should not love Vivitrol because it's abstinence-based or some other nonsense like that. People that use everybody when they get sick likes medicine. My wife is a cardiac ICU pediatric nurse at CHOP, right? When I get sick, she doesn't care because I have a full heart. There's no sympathy. She's like, suck it up. And that sucks, but it is what it is. I knew that when I married her. But that's how we treat people who use drugs. Everybody who gets sick wants love and medicine. And that's all we're saying. And do you know that most treatment centers in the state of Pennsylvania don't even offer these medicines? But you didn't know that. Isn't that asinine? It was the ridiculous thing ever. We need to make it rain naloxone. Okay, we need to have so much naloxone, and since we can't actually make it rain naloxone, we need to hyper-focus on giving naloxone to people that are most likely to experience an overdose. So I'm going to skip over some of this stuff. Syringe service programs, they do a bunch of awesome things. It's not just this handsome black man that thinks syringe service programs are good. This handsome black man thinks syringe service programs are good. No matter how uncomfortable syringe service programs make us, they are proven to save lives both by preventing the spread of disease, HIV, and hepatitis C, by connecting people to treatment that can put them on a pathway to recovery. And if you don't know, this is the top doctor in America. Alex Azar, he is the Secretary of Health, better than the first guy, but not by much. Syringe service programs aren't necessarily what you first comes to mind when you think about a Republican health secretary. We're in a battle between sickness and health, between life and death. The CDC thinks syringe service programs are awesome. What does Pennsylvania think of syringe service programs? Well, we don't like them very much. We've only got syringe service programs in 5 counties in the entire state, and really what we have them is in 5 cities. So something like 10 million people in Pennsylvania do not have access to syringes, and that is stupid. Furthermore, this is an updated map from the one Alexa shared, so we have had a couple of states that have expanded access to sterile syringes like Illinois, Georgia, and Florida. But what I want you to focus on is just the eastern seaboard. So Pennsylvania and South Carolina are the only 2 states on the eastern seaboard which haven't said, let's go all in with something that's got 30 years of research. Us in South Carolina. That's the punchline. Fentanyl test strips are another fabulous intervention. Some of my colleagues talked about how fentanyl is really pervasive, and we know when we talk about hard harm reduction practices, we want people to test their drugs and understand their supply, and research from a little place called Johns Hopkins and Brown University has shown us that when people are introduced to fentanyl test strips and they use them and they test them, more likely to engage in harm reduction practices like using with somebody else, having naloxone, having a plan if somebody overdoses. But both syringe service programs and fentanyl test strips, despite the fact that they save lives, are illegal in the state of Pennsylvania due to the Controlled Substance, Drug, Device, and Cosmetic Act. And what this says is, in a nutshell, is anything you could ever use to get high or anything that we might think of in the future is illegal. That's sad. That's not a joke. That's true. So we said that that's a dumb idea. We're going to do something about it because we cannot depend on doctors to organize. The Pennsylvania Medical Society, the Pennsylvania Society of Emergency Medicine, I've never seen them in the Capitol rallying for the health of people who use drugs. I've never seen the Nurses Association. I've never seen the social workers. As a matter of fact, all of those groups gave me the runaround when I asked for their help to support syringe service programs. So we said, we're going to go to the community. We're going to go to the people that give a shit. People in recovery, parents of loss, students who haven't been jaded by the profession, and we organize them. We've trained almost 300 people across the state of Pennsylvania in key legislative districts, and we're helping them organize in teams to start making a difference in the Capitol. We are looking at 3 key populations that are most likely to experience an overdose. Number 1, people that are getting out of jail. People that are getting out of jail are 40 to 120 times more likely to experience an overdose in the first two weeks that they got out of jail. Every prison should offer medication for opioid use disorder and naloxone distribution. Only one in the state offers both, and that's Philadelphia. Every county should have syringe service programs that needs them and wants them. Whether they want them or not, they should have them. And lastly, every one of our treatment centers should be offering medication-assisted treatment or medication for opioid use disorder, as well as naloxone distribution to their family members and their loved ones. And there's only a handful of programs that are doing that. We've already launched the first 2 programs. Our second program will be launched in partnership with the Philadelphia Department of Public Health and Care and Treatment Centers tomorrow at the Philadelphia Medical Society at 10 a.m. Feel free to check us out. So if you haven't figured this out, this has been a long commercial on why you should become an advocate. Number 1, you're white and have privilege and are a doctor. I am a person of color, a former addict, and only a social worker. I need you to use your privilege to make change. When you show up in your white coat at the Capitol, people listen. And I know you feel more disillusioned than ever. The politics are uglier than ever before. But despite your apathy, advocacy works. We are living in a critical time where people really care about this issue, and we can use the issue of the overdose epidemic to make changes to social determinants of health, racism, criminal justice reform, but I cannot do it by myself. The first time you advocate, you will be surprised at how engaged your legislator will be. We cannot do it alone. Shameless plug. We are having a conference on how you can be a better harm reduction practitioner. We're having a medical track. We're having a law enforcement track, a clinician track, and a community track. It's not that we really need researchers to come up with new solutions. It's that we need to figure out the ways to implement the shit we already know works. Thank you.
Never, never disappoint. So we are now going to open up to questions for our panelists. So panelists, please make your way to the dais. Water. I think we have a microphone in the audience. Steps on that side, yeah, safer. Yes, we have a microphone at the front of the room.
I think that was too much.
That was exactly right.
As our team gets seated, I would just like to give everyone a round of applause again for that. Okay, thank you.
Just start.
Please.
First,
So let's, you want to just say your name and if, who you're representing, if just yourself, that's fine. That's perfect.
my name is Aviva. I actually am an IT project manager for the health department, but I'm not here on their behalf. It's just my involvement, even remotely.
Yeah.
I've lost a lot of people to heroin over the life. I'm actually from Delaware County, which is, Dennis knows. And I'm always looking for harm reduction ways that, the ones that exist, but the ones that seem new and not talked about a lot. And I went to a really interesting talk at the Franklin Institute about CBD and the way that cannabinoids interact as an opioid antagonist. And I haven't really seen a lot about that. And I know that CBD and marijuana is still a Schedule I. And so there's a lot of, and then also CBD things have been sort of overblown right now with a lot of like overblown health things. And I was just curious if anybody on the panel had any ideas about that. Thanks.
Sure. So you may know that recently the state of Pennsylvania Department of Health expanded the number of conditions that you can receive medical cannabis for. To include opiate use disorder as well as chronic pain conditions that have been refractory to other treatments. Further, this is not a novel development. This is not something we just thought up. Again, like over a century ago, one of the most commonly prescribed medications for opiate use disorder was cannabis indica. Cannabis indica, opium, and bromides were the three mainstays of treatment back then. But yes, currently, I am one of several prescribers of, or not prescribers, but certifiers of medical cannabis in the city of Philadelphia, and I do prescribe or certify patients for the indication of opiate use disorder. Certify.
Not prescribe. Certified.
So related, the next citywide public health grand rounds will be on December 11th. Which will actually explore the role of cannabis in public health. Please.
My name is Dr. Kevin Moore, and I'm just going to talk for myself at this point. So I really agreed with many of the points about I'm a psychologist, and the not making behavioral health treatment mandatory and necessarily linking that to what we formerly called medication-assisted treatment, makes a lot of sense to me. I would also rush to say that I've spent my career training psychologists, training therapists, of many different types, of being able to provide services that have a low barrier of participation and a high amount of skills on the clinician's part in terms of understanding harm reduction principles, but also understanding a wide variety of different types of mental illness and treating that with substance abuse treatment at the same time instead of making them separate things. So my question really for all panelists, and I'd love if each of you could take a stab at this, is what does good behavioral health treatment look like to you in the practice settings that each of you work in or advocate for? Thank you.
Yeah, sure. I mean, I think that for me, having people accessible, so I'm an advocate, right? I don't even have an office. I work from home because I don't have a lot of money. But when I ran a recovery house, I had a recovery coach on staff, and he'd be like, oh, we're going to have these hours with people. And I'd be like, no, man, just be there. Just be there, be on the couch, be on the front porch. The real shit happens when you're smoking a cigarette, when you're watching the Eagles game. That's when the relationship is, that's where the rapport is built. And that's not what they teach you in social work school, but let's be honest, if we knew what the heck we were doing with opioids, we wouldn't have the problem we were doing, right? It's about the connection, it's about people feeling, you know, that the person they're working with is competent, whether they had a PhD in the streets or a PhD from Harvard, they gotta have that respect, and if you don't have those things, then it's not gonna happen.
Do you mind if so I absolutely agree with that in terms of having, having that relationship, having a lot of different, not just in an office at a certain hour, that model is incredibly limited. I think it has its place, but I think it's incredibly limited in its utility working with the folks that you're talking about. And you need a lot of training to do it well. You can't just show up and start doing it, which is often what people are paid to do. And when you don't have a lot of training and you don't have a lot of supervision and there isn't investment in learning the skills of doing psychotherapy, you get bad outcomes. And so usually what they say is individual therapy, it doesn't work for people with addictions. And I say, show me the studies and show me the training of the people giving those studies, and they don't have training in it. Of course you can't do a complicated thing without any training, really. So and this isn't like a pushback exactly, but I think that one of the things I would like to add to the many amazing things that you guys said is, and how do you get good behavioral health services to this population? I'm so sorry.
Certainly. Co-location is key. Yeah. And, you know, I'm a family doc. I've delivered 27 babies. I took care of the oldest woman in Philadelphia once. And I've done everything in between, including a small amount of behavioral health care. So I'm a huge admirer of the work of Stanislav Grof and Weber in transpersonalist psychology. I don't think that's necessarily the only way to recovery, but you're right. If our behavioral health consultants are not trained specifically in helping people manage substance use disorders, alongside whatever dual diagnosis they may have or not, we're failing them.
Yeah, we should stop giving all the money to cops and prisons and pay for social workers and their training.
So, can I pick this up?
To answer that question too before you ask me.
Oh yeah, sure, go for it.
So let's keep it moving, sorry.
Yeah.
Okay,
Feel-
I apologize.
Feel free to go up.
Fair enough.
Because
Ask more.
I'll try to keep this as short as possible. My name is Rory Fleming. I'm a socially awkward, non-practicing attorney who does a lot of policy and advocacy stuff.
Cheers to you, sir.
Yeah. So forgive me if this is rambling, but so I am very interested in how to try to get people who are interested in harm reduction, who are public health professionals, medical professionals, social workers, et cetera, involved in the local politics without being political, basically, because that stuff's really important, particularly because law enforcement is often elected on the local level, and people don't really know what they're voting for and who they're voting for. They don't really know what they stand for. And so criminalization is obviously a big problem, but I just want to give a brief anecdote of how important it is to get involved with this stuff and and basically then ask a question. So in Allegheny County, which is Pittsburgh, as most people probably know, this year there was a district attorney election, which is the chief local prosecutor. The first time somebody tried to primary this guy, he was a black, the challenger was a progressive black public defender who didn't want to prosecute marijuana anymore and wanted to do health-oriented stuff instead. They found out, they had their opposition researchers go in for the incumbent, and they found out that he talked about hating gays at his local church, which was a very conservative Baptist church. And so that guy was destroyed. And now there's an independent who's a progressive who wants to not prosecute marijuana, and the DA has sent in his opposition researchers and found out that 30 years ago, she, as a defense lawyer, struck 2 black jurors from a case against a white supremacist for basically racial reasons to make her case easier. And when the judge asked, why do you strike those black people, she said, because I hate fat people and they're fat. And so she's not going to win either. But the thing is, the prosecutors do really heinous things all the time too. And this is all because this guy just wants to make sure we keep the war on drugs, and will just absolutely try to destroy people. So to keep the scales balanced, and to really kind of echo what Devin was talking about privilege, often the people who are most hammered by the criminal justice system when it comes to drugs are people who don't really have the kind of power and privilege to walk into the room and get these people to care, and get the community to care, and vote in solidarity with their concerns. And so basically, I would be curious if you guys have any thoughts about how to get public health and social workers, doctors more engaged in these sorts of arguments on the local level to, then some ideas I would have would be town halls about this kind of thing in a variety of counties, not just Philadelphia, but say, for example, there is a race in Delaware County right now where yeah, I know, very long. And so basically, that's kind of my life struggle. I'm trying to get people more involved in this, because ultimately the state legislature is very important, but that's not everything, and law enforcement's local, so.
Yeah.
Dr. Anderson, do you want to tackle that?
I was going to pass that to Devin, but
I mean, so, in social work, in social work school, I was taught if your client is failing because the system is broken, the onus is on you to take on the system. And I'm not sure that public health people are taught that, or doctors are taught that, and it really has to start there. I mean, when I call deans of the schools of public health, they don't call me back. They're too much of a big deal. Outside of the dean of the school at Pitt has been really helpful, and I haven't called all the deans, only a couple of them. So I think it has to start at the top. The deans of schools of public health have to get involved. We see this new thing around vape cartridges, right? And the vape cartridges are illicit vape cartridges for cannabis, and the real cause of that is the prohibition of cannabis, right? But now what they're doing is they're tackling e-cigarettes, which people are using to quit smoking cigarettes, as the culprit, when it's not even the cause of the problem. Where's the op-ed from the dean of the school of public health anywhere being this is bullshit, this is not what's happening, here's the bad guy, here's the good guy, don't be bamboozled. E-cigarettes are harm reduction for tobacco, right? And that's not what we see. So if we don't have that leadership and that indoctrination early, I was radicalized in grad school, I was just a normal social worker before that.
I mean, and how do you change leadership? You got to do it from the ground up.
Yeah.
We need to be organizing our workplaces. We need to be making patient safety and outcomes a central point of workplace organization. The Public Health Management Corporation Care Clinic is organizing. We had a union vote with the National Labor Relations Board. And these are at the top of our list for things to do, is to ensure patient safety and create reforms around these social issues to really force the institution to pay attention to what they've been ignoring.
That's awesome.
Thank
you
you.
so much. Appreciate it.
So let's try it. Those were both great questions, but let's try to shorten it to the question.
Hi, I'm Alexandria. I promise I have a shorter question.
Excellent.
I'm a PA student and a public health student at Arcadia. And one of the things that Dr. Anderson mentioned was kind of breaking up policies instead of making federal policies, state policies for harm reduction. But my question is more about if there are state policies, what about conservative states? Like we saw with the SSPs, you know, those South Bible Belt Midwestern states, they're illegal. So is there, I guess what I'm asking, is there a balancing act between having states who are progressive and are willing to do these harm reduction policies, and what about the states, especially considering those states already have such harsh criminal justice policies against drug use?
Sure, great question, thank you. The role of lawyers is not to tell you what you can't do, it's to tell you how you can do what you want to do. So, the key to having a dynamic and responsive regulatory system is to find ways to do things that are plausible, that have high face validity. Our federalist system decentralizes authority, so we need to use every opportunity we can at the local and the state level to try things that are evidence-based, evaluate them, and then disseminate them. Research, I mean, I appreciate the idea that a lot of research just sort of sits there, but you know, we can also really use that policy learning process to drive reform. It does take, I mean, I'll say this as a lawyer, it takes lawyers figuring out creative ways to do things and not being just risk managers. So, you know, I'm hopeful that our sort of federal system can push these things along.
It's actually kind of funny. My name is Caitlin. I actually go to school with Lexi. I'm also a PA, MPH student.
Awesome.
My question actually builds off hers.
Okay.
How do we support the people in the states that are conservative if we do decentralize our drug policies? How do we support them when we know that their state and local governments are not going to do so? How can we essentially not abandon them as we cater to our own sometimes more liberal areas?
Yeah, can I offer a quick reframe? So we're in Philadelphia. Like 3 miles west is conservative.
Yeah.
You know what I mean? Like Delaware County's DA can't wait to arrest somebody for a drug charge. Yeah. We don't got to go to Indiana. It's right here. Yeah. You know what I mean? You can get involved with a local organizing shop. You could join the board, you could do a fundraiser, you can get in touch with the Pennsylvania Harm Reduction Coalition, Prevention Point Philadelphia. It's, you know, all advocacy is really local. You know what I mean? And there are great organizations in Pennsylvania, ProA, ProAct, Pennsylvania Harm Reduction Coalition, that all do advocacy around drug stuff. And like each one is more like liberal than the next, with us being like the lefties. Just find somebody and start doing something. Like, you know, that's always my thing, is like, you could throw beef and beer, you could be on a committee, you can go and get trained to be an advocate, right? But you gotta do something. And then practice with integrity and love when you get out into the field.
Thank you.
Hi, my name's Hannah. I'm a nursing student and a doula. My question is on a broad factor. What are we going to do to prevent the co-optation of harm reduction? I ask that because, I mean, clearly from the Harm Reduction Council perspective, I can see a lot of grassroots organizing and things like that, but from my perspective, I'm worried that, you know, people talked about medical marijuana. I'm worried that that's just like a huge capitalist venture. We know it's a huge capitalist venture waiting to happen and take advantage of our communities. We also see like lots of institutions, academic institutions, really interested in this topic, but that's just like paying a lot of people in positions of power around this topic. And as I hear more and more social workers and public health people who are in my circles, white folks with liberal arts degrees going on to further education, talking about harm reduction, I don't hear as much of the voices from the streets of our neighborhoods, and I'm concerned, and just wondering about what we're gonna do and what you're gonna do in your positions to hold your organizations accountable for really bringing this into like a transformative perspective. Does that make sense?
Yeah.
Okay.
Research by institutions is often extractive, and that's a real problem. And we need to think about ways to deal with that. And that includes researchers sometimes giving up the things that researchers really want. If you're doing community-based research, and most of it you should give up some of your authorship, and you should share all those privileges that come with your work, and that should be the norm. And we should think really seriously about the commodification of crisis. And I think we can't say that enough.
Sure. I think, go ahead.
Can I interject? Dr. Roth, I'd be very interested to hear your thoughts, particularly from the perspectives of gender-based approaches and disparities.
Yeah. So I mean, one of the things that we try and do, and it comes from the fact that I started at an AIDS service organization doing case management 20 years ago, long before I ever wanted to get a PhD or have a seat at a table like this. I mean, the only reason I'm at a table like this or have a PhD is because I figured I wouldn't do it any worse than anybody else, right? And so the things that we try and do in our research, one is we involve community stakeholders, whether that's the community organizations that we partner with or the clients that they serve and or public health practitioners in the design and evaluation of our research. We also try from the very, very beginning to think about how our programs become sustainable. So like the PrEP project that we have at Prevention Point right now, like we use Medicaid to pay for medications for almost all of our patients, and that's because if we were providing the meds, then the program would go away when we do. And so while it hasn't happened as quickly as we wanted, we think in partnership with our community organizations to think about how can we make this last. And unfortunately, it is slow, and we do include community representatives in our authorship. And we try and include students as well and think about ways that we're sort of creating these next generations of folks who can do the work. But you know, it's really hard to show up and stay somewhere and get folks to show up and stay in partnership with you. Even when you're consistent, even when you're reliable, even when you bring snacks and you pay cash, all of the things that we do. And so that just goes to show that we still have work to do, right? When researchers talk to me about they can't recruit into their studies, my first question is, well, what are you doing wrong, right? Like, did you talk to people? Did you, did you talk to people? Did you ask them what it would take for them to be where you are when you want them to be there for as long as you need them to be there, right? Like, what is it about the way that you need to shift your practice? And I think that the only way you can do that is by working in conjunction with the communities that you serve. In the case of my research, it's often women, and working with them to try and put these things into a nice package.
So I'm going to just add one little thing. That question is something I've thought a lot about, actually, and I've questioned a lot. But I will say this: the purpose of venues such as this is really to educate and share the evidence and share the best practices, and that is no different than anything else we do in medicine, in social work, in nursing. The goal is to see that there is fundamental research basis for harm reduction approaches. It does not necessarily need to be in the dark corners. In fact, we want it, so I speak for myself in this, we want it to be how we approach vulnerable populations, and whether that be those who engage in high-risk behaviors or those who have been traditionally marginalized or felt marginalized from our health system. These are all ways to engage, and these are ways that we change our approaches based on lessons that we've learned over decades, over centuries, as Dr. Kochiar told us. So it is there. You know, in everything, there's those who jump on the bandwagon and sort of throw out trendy terms. But at the core is really all of us learning from each other on how best to approach those who need care and those who need services and those who need help in whatever way that is.
I would also add to that it's about control, and it's about devolving control back to the people who you're trying to serve. If you have an organization and it doesn't have a board that reflects the people you're serving, you don't have an organization that's serving people. If you have a community advisory board and it's all your friends, you're not doing your community advisory board the right way. Listen, I've seen the future. It's in Canada, and they have And they have these little things called Steri cups, and they're prepackaged sterile heroin cookers. And they come with this little nitrocellulose cotton and a little prepackaged alcohol pad, and the free market took care of all of that. What the free market's not going to take care of is centering the voices of the people who are most closely affected by the problems that we're trying to work on. So that's on all of us.
Yeah, I'm going to take a stab at this too real quick. So there's this woman in Pittsburgh named Alice Bell, who, I don't know if you know her, but she does a lot of research, and she like yells at me when I do stupid stuff, so that's part of it. And then also, like, I talk to the people that run syringe service programs, right? And, you know, I am not the most radical person. I just seem radical compared to all of you. I'm actually quite pragmatic in a lot of ways, and sometimes I gotta go back to them, like, I can't get that shit done. It's just not gonna happen, right? So I think that, you know, the bonus is, as a person in recovery, as a black man, I know exactly what the war on drugs is about. But that doesn't mean that I know everyone's experience. I just know how it messed my life up. And I try to bring that with me everywhere. I think a lot of people that do this work as advocates are like, I am a white lawyer, and I have an MPH, and all of these research studies. And that's not what I come with. That's not the sass that I bring. I bring like, yo, this is my life. This is my friends' lives. Get it together. And that's why I try to surround myself with who's people that are on that same, they have that same why as me, you know? I hire people that are in recovery. I hire people whose parents had problems with drugs, because like those people, it's not just a paycheck, it's their whole life. And that's what I try to center it in. But like, you know, I get sniped from the left and sniped from the right. We're all doing the best we can.
Hi, good evening. My name is Connor Watson. I'm a student at Drexel University studying health administration. I'm also the son of a former heroin addict. My dad's been clean nearly 30 years. His road to recovery definitely took a lot of worse squiggles than the one we saw in the graph. But my general question to you is, I found in my studies, the largest challenge to harm reduction programs is actually this moral hazard counter-argument. And you hear a lot of politicians and people that are against this say, you know, we can't have a needle syringe program. People are just going to be running in churches and shooting up, or people are going to be smoking crack in schools, or what have you. And I guess my question is twofold. We also see this with the opioid epidemic, but where was this when crack cocaine wiped out North Philadelphia?
Dr. Anderson, I feel like you might be able to address some of the historical.
I mean, I'm not sure I have to. I don't.
It's true.
I think, no, I mean, everything is, you know, race produced the war on drugs, and it continues to moderate its application and produce harms, racism. So, yeah, I won't say more. I think I'd rather just hear Sterling. That's all right.
Hi, Sterling Johnson. So I'm just wondering your opinions generally about how we do focus on like getting to zero. I've seen some like 30-year studies, right, from Switzerland and from other cities where harm reduction taken like entirely has changed just the nature of the city, right? So just wondering, is there a path to, you know, 0 deaths? You know, there are 8 deaths in Portugal from overdose compared to 70,000 in the United States. You know, there are 8 deaths in Portugal compared to, you know, 3,000 over 5 years in Philadelphia, which has a much smaller population. So what's the path, you know, for 0 overdoses, 0 HIV, you know, very limited transmission of HIV and Hep C. I'm wondering, like, how does research come into that as well? And can you just kind of expound on how we get there?
I think it would be a massive lift, which is not to say that it's not impossible, and which is not to say that it isn't something that we should be holding ourselves accountable to as a goal. And the only thing that I can think of is that sort of triad that I showed before, where you've got structural level changes that are addressing the war on drugs and prohibition, where you're making biomedical interventions available to people, which would include, not only like prescription heroin, hydromorphone, naloxone, medication for treatment, and then also looking at behavioral interventions. And if I handed the mic to Ben, I know what he would say, which is we would address adverse childhood experiences in every single system that touch the children of the United States and of the world, that then create the greater likelihood that people are going to have the kind of trauma and engage in these in behaviors that put themselves at risk for health harms. And so it's like, I don't know that there's any single approach that can address such a massive and expensive and important set of social circumstances, one that we, frankly, as a society, have created ourselves.
I think we need to take the bite that we can. Right now, there's a court case in federal court about the legality of supervised consumption spaces, and we're going to work on that. And then the next bite is going to be hydromorphone-assisted treatment. And then the next bite is going to be decriminalization. I think with those things, we can get a good foothold towards zero overdose deaths, which you're right. Every single one of them is an atrocity because it's of our own making.
Hi, my name is Reha. I work in the ER in a hospital. I'm pretty nervous standing up here, so I'm sorry if my voice shakes. Okay, I gotta be louder.
I'm sorry, can you speak up just a little bit?
So we have a research survey that we do, and we tell our patients that we're gonna provide patients who come in with opioid overdoses or are at high risk, not just that you come in with an opioid overdose, that we'll provide you free Narcan. We'll also give you a refill if you come back and you've used it for whatever reason. But every time I have a discussion, not every time, that's an exaggeration, I actually do receive a lot of pushback from these patients, and I've heard, I don't need your free Narcan, I can get my own. Why are you asking me that? I'm not an addict, but you're here for an opioid overdose. You're getting treated in this hospital for an opioid overdose. I'm also not related to the social worker. I'm not related to, I do work in the hospital, but I'm not your care provider. I'm just going to give you free Narcan. How can I change the conversation with them? Because I just want to help them. I am going to ask you a few research questions, but if you're not comfortable with answering those questions, that's absolutely fine, but I want to provide that free Narcan to them. So, as you said, Dr. Roderick, what you asked the question, what am I doing wrong, right? So, what could I possibly be doing better in that?
I think there are lots of people who could probably take this question, but I think you're asking yourself the right one now, which is, what am I doing wrong? How am I approaching somebody in a way that's making them reject a service that they may or may not need, right? And so harm reduction would say that you need to start where the person is, and then think about what is it in the way that what are you potentially presuming about somebody, or what? Because you don't know how somebody got to the hospital or why. It could have been any one of our moms with a benzodiazepine, a glass of wine, and then oops, a pain pill, right? And so who are we to presume anything about anybody?
Right.
As a clinician or as a social worker, what would you guys suggest?
I'd be like, it's not for you, but somebody else who might, it's fine, just take it, it'll be good. You know what I mean? I think that I'm just trying to find excuses to give people naloxone. Something I've been thinking about a lot lately is can we just give drug dealers naloxone? Can we put up a butte table across the street from the set?
I have sometimes that way. I'm maybe you won't need it.
But, yeah. I just think there's just just take it. It'll be fine. Just take it. And everything, I'll take it. You know what I mean?
My second question is, as an immigrant, as a non-white male with high power, no offense to the white males with high power here.
No, smack them down. Smack them down. Smack them down. Go with it, sister.
What can I do apart from volunteering to bring about change?
You can get promoted.
Yes.
And then you help other people get promoted. Like we got a band together.
Okay. I will work on that. Thank you.
Thank you.
Okay, this will be our last question of the evening, and then we will open up to the reception and more questions and conversations allowed.
So I'm Zachary Pierre, and I work with the viral hepatitis program at the health department, but I'm not representing them at the moment.
Okay.
So my question is if you all could speak to sort of best practices for supporting individuals with co-occurring substance use. I pretty regularly speak to people who tell me that on a daily basis they use, heroin, fentanyl, Xanax, meth, K2, and I know there's only really biomedical interventions for one of those, so how is that really affecting harm reduction for those patients with more complicated needs?
Doc.
So, you're right. Our treatment modalities for non-opiate substance use disorders are behavioral. and getting folks...
And evidence-based.
And that is true, exactly. So, we meet people where they are. When I'm on the mobile addiction medicine van, and I have a patient who is using 5 different substances, and one of them's opiates, the thing that I can do, the thing that I have at my disposal is buprenorphine and naltrexone and referrals to methadone programs. I get them stabilized in that direction, and I, at the same time, make the offer of referral to behavioral health treatment. That comes with a warm handoff, meaning that one of our caseworkers or myself contacts the agency that we're referring to directly, speaks with somebody there about the case, gives them a little bit of background, and eases the transition between the two organizations. Co-location of services would be better than that. But I think one of the other points that I gather you're trying to ask about is harm reduction strategies for things like meth and cocaine use. And if you look at the services that Prevention Point are offering right now, they're included there. Crack pipes, for instance. Safe sex equipment. My mind is now drawing a blank because I'm standing in front of 300 people. But there are myriad things that we are doing, and there are myriad other things that we could be doing.
Thank you.
Awesome.
Thank you all very much
Don't get
for
up. I
a
wanna
great
get a good picture.
discussion.
Don't get up. I want to get a good picture.